All right, so the basics for protocoling any CT study is that you need to approximately know what the protocols entail, and then the specific topics that we're going to discuss, because those are questions that come up all the time. It's when do you gate or not gate a CT study. Then we'll talk a little bit about trauma, lower extremity CT angio, because it's also a not uncommon source of confusion and error. And finally, a really important issue is for abdominal CT angiograms, when to add delays or which protocol to pick so that you do not have to add delays. Now, a very basic principle for protocols is essentially, what does it really mean? I mean, when you think about the CT acquisitions, you can categorize the acquisitions parts into the CT study, and which contains a lot of CT series. So the CT study is where you have an accession number for and what gets billed to the insurance companies. And then within a study, that is, for example, a CTA or a liver study or something, you usually have a lot of series included, which can be a non-con, a post-contrast series. It could be a delayed phase, but also it contains the topograms or scout views, as well as smart prep series, etc. And the combination of all these series that are included in one of the CT study is essentially summarized in the CT protocol. The CT protocol essentially prescribes the sequence of acquisitions, which means all the series that are necessary to answer the clinical question. But it also includes the reconstructions. If you have some MPRs, coronals, and sagittals, it's also included in the CT protocol, as well as some reformations. And also, for each acquisition, you can have more reconstructions. So you can have from one abdominal arterial phase, you can have thin sections and thick sections, etc. All of this is included in the CT protocol. Now, the challenge often is to pick the right protocol for the right clinical indication, but the mechanism how to do it, let's say you know already what kind of study you're going to protocol. Let's say somebody orders a CT abdomen and pelvis, then you'll go to your Smartform in Epic, and then you can, based on the region, the protocol, and the contrast and the route, you can essentially customize your protocol. Essentially, it's relatively easy to click on each of those, and then once in a while you need to change something. Once in a while, if something is not ordered correctly, you may want to route it back to the technologists so they can change the order, for example. Sometimes for coronary CTAs, we often route them to the nurses actually, so they can take care of ordering the meds. So that's the practical aspect of how to do it in Epic. So the true protocols, so the true exact prescription of what has to happen for an acquisition is not on paper, but it actually resides on the scanner. It's on the scanner where you can truly pick the protocol for a given acquisition. And so what's still important for you to pick the right protocol for the right indication is that you need to have some idea of what's in your protocols and what elements are usually in a protocol that is on your scanner. So for example, if you order a CT angio, you should know that it usually includes a non-contrast scan, whereas if you scan a trauma CTA, it doesn't have a non-contrast scan. So those are these little nuances that you want to know in case something doesn't add up and you want to change something. We do obviously have, thanks to Lior, a documentation of the protocols, and he showed it earlier, but there is in fact now finally an online version where the protocol principles are listed. So it tells you in principle that for a CTA you have a non-con and a post-contrast and a delayed phase if it's a stent graft, and you can go and find all these online, and there's not only the CTAs, but there's also the neuro protocols, the chest protocols. Everything can be found there, and it's really quite informative to have this in mind. Although once you're here for 2 weeks and protocol a couple of studies, you probably will know most of the mechanisms already by heart. So just organizational wise, so that you are aware of it, so the responsibilities of the protocols, like the protocol development and what's on the scanners, is within the sections or within the divisions. So for example, the body section chief. So currently Brooke would be the person responsible for body protocols, Max for neuro, myself for cardiovascular. And so my role as the director of CT, together with Lior, who is essentially the protocol technologist who's responsible for keeping this all together, and Ja, who you just met, who is a medical physicist. So we are kind of in charge of overseeing everything and making sure that the protocols are kind of similar across all the sections. So for example, we have weight-based injection protocols, and we want to have this obviously for all sections and not just for chest and for neuro, but not for the other sections. So that's the main role that we play here. And also the protocols are important to be documented. There has to be version control, thanks to the ever-growing need for documentation and accreditation, etc. We have to keep track of this. And then another not so easy thing is to implement this. If you have a new scanner or you change a scanner, if you change a protocol, to implement it across all scanners is very difficult. So just imagine if somebody decides, as you would think it's very easy, well, why don't we just do coronals on all renal CTs? And you have to imagine this means is first we have to decide how to really do it, but then you have to implement it on all scanners. But every scanner where a renal protocol is included has to have this additional series, and so keep in mind that these changes are not that easy. So it's not like a little dingy where you can change direction easily. So we are like a behemoth of scanners. It's like the Titanic where you want to change course, and once in a while I'm afraid we're hitting some icebergs. Now, also it's important that the protocols are somehow linked also to our dose reporting, as we just heard by Ja as well. Now, just a quick word. Essentially, the main building blocks for any CT protocol are the different phases. And you usually have a non-contrast scan, which is like in head CTs. All CTAs except traumas or PE studies have non-cons. You have arterial phases, usually which starts 8 seconds after the contrast arrives in the aorta, using SmartPrep or similar. Then there are late arterial phases, which you, for example, use for bowel wall or for pancreas, which means that you start to scan 16 seconds after the contrast arrives in the aorta. Then there's obviously portal venous phase and all kinds of delayed phases. You can even type them, you can pick them on your protocol page, or just pick renal delays, for example, on your protocol page. So that's essentially what you want to keep in mind, and that's the main thing that makes up a protocol and which you should try to memorize. So let's start, for example, with some protocols, and so that you should know that if you protocol a PE study, what you're going to get. So if you protocol a PE study, what you're going to get is a single acquisition. So you get a CT angio during a pulmonary arterial phase. There's nothing else. There's no non-con, there's no delays. That's what a PE CT entails. If you order a CT angio chest gated with abdomen pelvis, then what the scanner protocol requires to scan would be first a non-contrast, that would be chest, abdomen, pelvis, and then you would have a gated scan through the chest, and during the same injection you also have a non-gated CTA of the abdomen, pelvis. So there is no delays for that part of the acquisition. Now, if you order, for example, a CTA chest, abdomen, pelvis with stent delays, so who knows what you're going to get? Well, first you get always a non-contrast, because it's a CT angio. Then you get your CTA, and then in addition, as you would expect, you get some delays that over the stented region. So you get stent delays if the stent graft is, for example, in the abdomen, then that region will be in your stent delays. If you order a CT angio chest with abdomen pelvis trauma protocol, then you will get a CT angio of the chest. That's the one CTA that does not have a non-contrast. And then you get a portal venous CT abdomen pelvis. So that's a very commonly used protocol, and usually the ED guys order this, and this is what usually gets scanned. Now, if you see something like this, a CT angio chest abdomen pelvis, right, and in this trauma setting, then what you're going to do is you are obviously not going to do this at all, because if you do a CT angio of the chest, abdomen, pelvis, then you can see the vessels, but you cannot see anything in the abdomen. So you cannot see active extravasation. You will not be able to see the to interpret the liver or the spleen. So that's a big mistake to do a CT angio chest, abdomen, pelvis in a trauma setting rather than a standard CT angio chest with abdomen, pelvis, which means it is a portal venous phase acquisition. And the reason when these problems usually happen is when the ED or the trauma team, they think that there is, or they know from outside study, there is some active extract from some vessel somewhere, and then they don't order the routine protocol, but they order a CT angio chest, abdomen, pelvis. But you are the one who sees the protocol, sees the order, and you have to protocol it. So you cannot always just essentially check in the protocol exactly what is ordered. So that's important. Now, if we do it the other way around, so if somebody orders a CTA or any study because they want to evaluate the ruptured AAA, then what you would order would probably just be a CT angio. A CT angio should be okay because you will get non-contrast acquisitions and you get your CT angio. And for ruptured CTA, that's all you need. Now, if you have a study that orders, let's say, an abdominal scan for a GI bleed or for a mesenteric ischemia, and most of the time the clinicians might order just a CT angio, and that's something that you also should be careful not to do, at least not without thinking about it, because if you order the CTA, what you're going to get is, again, a non-contrast CT, and you get a CT angiogram. But for GI bleed and mesenteric ischemia, that is not enough, because for GI bleed you need to see if that active extract accumulates over time, and for a GI bleed you also need to see if the contrast accumulates, for example, somewhere in the GI tract. So those are the studies where you always have to include a portal venous or even a delayed phase. So what you have to do in that setting is you either have to order, if you want a CT, you have to order a CTA plus add manually a portal venous phase, or you can add manually, you can write please do a delayed phase somewhere. It doesn't really matter when, as long as you do it. Or you can just click, there is a separate order for a GI bleed and for a mesenteric ischemia protocol. But the process that you have to catch the potential mistake that somebody orders a CTA only for a GI bleed and mesenteric ischemia, that's really the clue. If you then add a delay to a CTA, or you pick a mesenteric ischemia or a GI bleed CT angiogram, would both be appropriate. Just an example, here is a patient who had a non-contrast scan. This was a patient who was found down and had a non-contrast CT. You see a lot of blood in the patient's stomach. In the arterial phase, there was really no source of bleed seen, and only in the delayed phase, in the venous phase, you can see that slowly some blood accumulating here in the patient's stomach and then filling it. So there was a massive GI bleed that was only seen on a delayed phase. So really something that you always want to include if anything with bleeds is in the differential. The same, this was a lucky case, a patient with a sigmoid diverticulitis bleed that was seen in the arterial phase, and you see that the contrast here accumulates then in the late phase in the sigmoid colon. Again, you want to have delayed phases here, so you identify that it's really blood extravasating. The sensitivity increases dramatically if you add this venous phase. Now, the second point that I want to cover is when to gate and when not to gate. Essentially, when do we use ECG gating and when do we not use ECG gating. So for a coronary CT angio, obviously we always use CT, we always use ECG gating, but the gated chest protocol we use obviously not in everybody. The reason why we use it is mainly because it reduces pulsation artifacts. The disadvantages are that it does require that somebody has to put ECG leads on the patient. It's also somewhat slower than a non-gated acquisition. It also has a slightly higher dose depending on what kind of technique or gating technique you use. So a few studies that we do not gate is trauma CT angio. And so the reason is simply because, first of all, the traumas that you don't see on a gated studies might only be maybe ascending tears or something like that, but the chances that an ascending aortic rupture traumatic survives it to a hospital is so exceedingly rare. And in the last, I think, 19 years, I have seen 2 lesions in the ascending aorta that are related to trauma, whereas lesions near the subclavian artery, near the isthmus, are way more common. Then when you think about how many trauma CTAs we do and how many are positive, it's not a lot. So you don't want to use gating for everybody who has a trauma CT angio. Particularly, most of these patients are also young. Right? So people like tonight will be a good day. It's a nice weather. Of young people hanging out, driving fast, drinking too much, and then they end up like this, right? So that I think is quite straightforward. So people know that we don't use trauma gating for trauma CT. But another setting is that if you do a follow-up for a trauma CT, if a patient got a stent graft, you also don't need to gate it, obviously. And here's an example of that. So this was one of these unfortunate gentlemen. He had a major trauma, had a whole body CT, he also had head CTs and everything. You can see he had a complex fracture of the femur tibia, but his most severe lesion, obviously, or life-threatening lesion, was that he had an aortic rupture, which you can see here on the sagittal formations. And aortic ruptures that require treatment do not need to be gated. If a traumatic aortic lesion is so subtle that you have a hard time seeing it on a non-gated study, usually it doesn't need to be treated acutely. So it's really not necessary to do that. So that's clear. This was not a gated study, but now the patient comes back just a few days later for a follow-up. And now, unfortunately, what was done in this patient, that you actually only need to have a CT angio of the chest to follow his aorta. What was done here was it was ordered as a whole gated chest study. So he got a non-contrast CT angio, chest, abdomen, pelvis. Then he got a gated chest plus a non-gated abdomen, pelvis. As you can see here, these are two separate scans. The gated chest has a relatively high dose, as you can see here, and he had a stent delay. So a stent delay is also not necessary. A stent delay is usually necessary if you have an aneurysm that was excluded, but not for a trauma case. That's really not necessary. So this patient got a total DLP of 2600, almost like 40 millisievert, and that is certainly not necessary. When do we gate? Obviously, for suspected dissection, I'd rather gate than not gate. Then for type A dissections, when they come from outside, which means that we repeat them if a lesion is suspected, but we are not sure if that's really the case. And sometimes for triple rule-outs, which we actually do not really do. But that's a typical example of a patient where we should repeat this study. Gated, this was actually also a trauma case from outside, referred for a repeat scan for a traumatic dissection. And as a side note, I would argue that there is in fact no traumatic dissection. This doesn't really exist. So you can have a traumatic rupture, you can have a traumatic aortic injury, but not a dissection. So when you look at this patient's CT here, you see this double contour in the aorta. But if you look carefully, you see also double contours along the pulmonary artery, which already would make you a little bit suspicious that this is really in a dissection or anything. Again, you have see here. But this study was then repeated, mostly to assure them or prove that it is an artifact. And here's a repeat gated study. It was a very obese gentleman, so it's a bit noisy. But what you can see clearly on the gated study, there's no dissection or aortic abnormality at all. If we go further down again, this double contour here is not existing. Again, if you have a double contour also in the pulmonary artery on the same slice, this kind of really raises the suspicion that this is an artifact and not a true aortic lesion. But when people come in with these kind of outside studies where the surgeons are pressured to do something, you can help them out by repeating this with a gated study and proving that this is in fact nothing serious. Now, lower extremity vascular trauma, that is also a topic that is often protocoled not ideally, and that's a lot of responsibility also on the technologist side, because the technologists actually see the patient and they really know what the lesion is by just looking at the patient. So the background to that is that when you pick just a standard runoff protocol, and we have essentially 3 runoff protocols that would fit in this context. So the standard runoff protocol, that I'll touch on a little bit, This is for patients who have peripheral artery disease. So these are patients who have claudication or critical limb ischemia. So there's patients who have severe atherosclerosis. Then we have the trauma protocol, which is a customized protocol. This is a protocol that has a lot of moving parts, so I'll show you. There's also a dedicated pediatric trauma runoff, which is just a single run, for completeness sake. Now, in patients who have peripheral artery disease, like in this patient here, who did a CT angiogram, you can see that the patient has this is a normal side, a normal superficial femoral artery, which is completely occluded here. So this is a chronic process, and you can imagine that if the process is as bad, that it will take a long time for contrast to trickle all the way down to the arteries. So we have to adopt a lot in our protocol to make sure that we get decent image quality. Also, the role of imaging in these patients is not necessarily to make a diagnosis of peripheral artery disease, but the main reason why we do these studies in these patients is because we want to show where the lesions are so that the surgeons know how to treat them. And that's reflected in the standard runoff protocol. So the typical protocol for a runoff, and this is what's going to happen if you pick the protocol, is that there will be a non-contrast of the abdomen pelvis. Then there will be a CT angio from with abdomen pelvis all the way down to the toes, as you can see here. Usually it's acquired within 40 seconds. Then we have a second acquisition from above the knees all the way down to see if there's any later filling, if the contrast trickles down really very much too slow. Now, if you pick this protocol, the runoff protocol, in a trauma patient, this may not be ideal, because let's look at this patient. The patient comes with a 19-year-old man with a gunshot wound to the right thigh. So if you do a standard runoff protocol, you would start with non-contrast of the abdomen pelvis, which is completely irrelevant, but there's no need to do this. Then we will do a CT angio that goes from the aorta all the way down to the toes. That's actually good. I don't think we need to start very much higher than the groin, because the rule for traumas is that whether you have to start one joint above the lesion, not much higher, and you always have to go all the way down to the toes, because if there's a lesion in the SFA, if anything happened, if anything embolizes it, it will be caught down in the toes, or at least below the ankle. So a CT angio of a trauma should always start above where the lesion is expected or known, and it should always go down to the toes. If the vascular surgeons say only scan the thigh for a CTA, then you obviously will not listen to them. You always go to the toes if you do a CT angio for that. And then if you would do delays in this case, then it would go through the lower leg, which is also pretty much unnecessary, and you really don't need to do this. So the right protocol is relatively simple. You can still want to do a non-con, a CTA, and a delay, but you just want to move them all to the right spot. So the right acquisition for this patient would have been to do a non-contrast through the thigh. The reason why you want to do this is because if it's a gunshot wound, you want to see if there's foreign bodies, if there's little shrapnels, and sometimes shrapnels are difficult to distinguish from contrast extravasation if they're next to the lesion. So you want to do the non-con just where the lesion is. Then you do the CTA starting above the lesion all the way down to the toes. And then the delays you also want to do obviously where the lesion is, because you want to see if there's any delayed enhancement or something that fills in that space. Another example, a patient with a thigh hematoma after trauma, and so they wondered if it was actually a trauma or if it was an arteriovenous malformation. So it's kind of okay to do the non-contrast through everything. At least the thigh was included. Probably the pelvic part and the below knee we could have skipped, so it would have been enough to just scan through the thigh on the non-cons, and the CTA was good. And for some reason the delays was just picked from the original runoff protocol, which is obviously unnecessary. So again, there's a lot of room for error, but if you think about what you really want to see, it's very straightforward. You have a block non-con, you always do the whole CTA, and then you have a block for the delays, and the delays and the non-cons you just move wherever the lesion is. So it's not that complicated, but obviously in the heat of the moment, sometimes you may forget. And here's an example of and then here's the reason why we would have liked to have the delays on in this particular patient, because you see on the non-cons it is obviously just a big hematoma intramuscular. On the CTA you see some kind of little vessels here, but I'm not sure what this vessel is. Is it a normal vessel? Is it a squished side branch? And there's something enhancing here. So if I had a delayed phase, I would be much more confident in saying that, well, this is just a little branch vessel, or this is actually an active extravasation, because without the delayed phase, I can't actually tell. Then here are a couple of other points I want to make, just to scare everybody about this is all things that happened and errors that do occur. The point being here is that if the orders that come in are not necessarily what the protocol should be, and we can obviously complain about the ordering physicians, that they are sloppy, they don't give us clinical information, etc. But when you ever try to sit behind their computer screens and try to find the right order for their studies, it's actually not easy. So I think our end is easier in order to protocol the right thing once we know what the story is. And but no matter what, we are in charge and we are responsible for what ultimately gets scanned. So it's our responsibility to pick the right protocol for even the wrong order. So here's an example. A 20-year-old woman had a talar dome fracture, and they were doing a CTA, I'm not sure why, to check the fracture healing. Right? So this might have been a high-resolution bone scan for the MSK guys, but whoever protocoled it didn't pay a lot of attention and just clicked the CTA, the runoff protocol. And now you have scan a non-contrast abdomen pelvis, a CT angio through everything, and delay through the lower legs for a talar dome fracture. So again, these things can happen, but they shouldn't happen. Right? 80-year-old woman, she had a history of breast cancer. The comment, this was ordered as a CT angio for a deep inferior epigastric perforator protocol. That's actually a protocol that includes usually the abdomen pelvis from the umbilicus to the groin. In the comments, they said, well, we also need to evaluate the thoracodorsal artery. Again, we ignored it and we just scanned the abdomen pelvis. Then we get a complaint and then we have to bring the patient back. So again, it's protocoling is tricky. There are so many moving parts, and it's one of the more time-consuming things because a lot of things can be potentially wrong. 56-year-old woman, she had a history of DVT. Some of the ordering physician clicked CT angio lower extremity. What did we do? We did a CT angio of the lower extremities. Did we see anything? Could we see anything about the veins? No. Again, complaint from the IR guys, and we have to bring the patient back, and that's something you really want to avoid. Not because it's the IR guys, I mean, it's more in general, you want to avoid having callbacks. So, trauma 99, a young man, motor vehicle accident, and the comment was suspected pelvic bleed. What was ordered? A CT angio, chest, abdomen, pelvis. Again, if you do this, and which was done in this case, you have a CT angio, you have an arterial phase, and you do not see anything about the liver, about the spleen, about anything else. So that's also a major issue, because then you can't actually interpret the whole study, right? And the other problem is if then it ends up on the cardiovascular imaging board, if it comes up, and you cannot turf it back to the body, folks, because there's not even a portal venous phase. Right? If a portal venous phase, you could, okay, can you help me? But otherwise, with the CT angio alone, unfortunately, it's in our court. You cannot interpret these studies. All right. Let me just summarize here, so they have also 2 minutes for questions, that CT protocols they all reside on the scanner, they encompass all the acquisitions for a given study, and you do need to know at least some of the basics. So you need to know approximately what kind of non-con or arterial or portal venous phases are part of the protocol. And also important, an order by a clinician is not necessarily the protocol. So you don't trust anyone ordering a scan, because in the end you are responsible, and you'll be gonna talking to the judge if anything goes wrong, and not the ordering physician. Right? The question to gate or not to gate, again, I showed you some examples. The principle is if you need to reduce artifacts in the ascending aorta, then it's necessary. For dissections, we always use gating. The exception is trauma, and trauma really you don't need to gate. For extremity trauma, again, it's different than the runoff protocol. You can pick the runoff protocol, but you still need to move the non-contrast box and the post-contrast box for your acquisition. And for the abdominal CT angioids, it's really important to not forget that a CTA alone does not have a delayed phase. So if you need a delayed phase, like in patients with suspected GI bleed, in patients with mesenteric ischemia, or in trauma patients, obviously, where once in a while a CTA only is ordered, you always need to add delays. And with that, I thank you for your attention.